offer for them to have that opportunity to participate in what it is that you're doing. So it comes across more as participatory. And then lastly, what do you fear most about the treatment? So for example, again, some of the things, if surgery is a treatment for the given injury, I'll go back to the example of an ACL injury, and someone has to have surgery to repair that. They may fear going under anesthesia as opposed to doing a block where you just numb them from the waist down. They may fear just being in the hospital in and of itself. They may fear the needles. So trying to gather the information about what it is they fear about their problems, what it is they fear about the treatment, how they would like the treatment to progress may go a very long way in helping that patient to feel more comfortable with what is going on and more comfortable with you. And that way, again, you have gathered information so that you can make an educated and informed decisions about what it is you want to do with your patient. So I've talked a little bit about what to do with the history. Now we're going to talk a little bit about inspecting and observing, what to do when you do your inspection and when you do your observation. Physical variations. One of the more obvious things that you're going to see, of course, is the person's skin. You have to do a skin assessment. And if the person is lighter skinned versus darker skin, it's certainly going to be easier to see certain things than other things given the color of the person's skin. When assessing patients with darker skin, you're going to want to use natural lighting whenever possible, though I recognize that many athletic training rooms are in the dungeon, so to speak, or that we don't have windows. For those of you that do, you are lucky and it's wonderful. But nonetheless, if you don't have windows, having bright lighting makes it much easier to be able to evaluate skin tone a little bit better. Give you an example. I had a football athlete once who happened to be very dark skinned and sustained a 3rd-degree hamstring strain. And the blacking and bluing, the ecchymosis on his leg that resulted from that injury was the same color as him. So it was through seeing just the edges of the bruising where there was a little bit of a line and careful looking with good lighting that you could actually see the discoloration. Also, oftentimes if you can't differentiate that, certainly by touch, the warmth, you'll know that it's very, very warm. There may be some swelling associated, so you may have to rely on other things besides the color. You may have to rely on the touch. You may have to rely on that the person is warm to know that something else is going on. You may have to check for certain other illnesses, the lips or the nail beds or the palms, the soles, for accurate assessment. Jaundice in individuals who have yellow undertones, it may be difficult, or someone who is darker skinned, it may be difficult. So looking at the eyes may help you there because the eyes may change colors. The whites of the eyes become a little more yellowish. Cyanosis, when we have the blueness, particularly for some individuals in the Mediterranean areas have bluer lips, so it's a little more difficult to ascertain whether or not the blue, understanding what naturalness of their lips look like, different from if they're blue because they're losing oxygen. Again, with pallor or the someone who loses color, we talk about turning white. Well, if you look at me, I'm not quite going to turn white if I have pallor, but nonetheless, I won't look as brown as I am. I will certainly look less colorful. And also, there may be some other red tones that may come about. You may see ashiness in the skin that helps you to know that that skin color is not normal. As we look at Other things, as I mentioned, with the redness, the ecchymosis, you may need to assess by touch. You may not be able to assess by the color of the skin. So it's important to think about that. Um, and then lastly, with physiological variations, some skin conditions that you may need to be aware of. Keloids, for example, when we get the thickening of the skin, is very more likely to be common in African Americans, although there are others who experience keloids as well. You need to know if your patient is prone to keloids. If someone is going to have surgery, the surgeon needs to know. There are things that the surgeon can do to try to minimize the scarring. We know that ultrasound can be used to help with scarring. So if it's appropriate over the particular body part, then you might would use ultrasound to try to minimize some of the scarring that might would take place due to keloids. And there may be things that people should avoid. People who are prone to keloids should not have the laser treatment of the eyes in order to correct their vision, because they may keloid, they may not, the body may not heal properly because of that, and therefore they may be they may be left with more eye problems than they started with. So knowing that becomes real important as you have conversations with some of your patients. Moving on and talking about palpating. Touching people. As athletic trainers, we are touchy-feely types. We have to touch individuals in order to do our jobs. However, not all of our patients want to be touched very much. So as I like to tell my students, sometimes you touch them a little bit, you find what you need to find, and you get your hands off of them. I had a patient once whom I was taping the person's ankle. And the athlete said to me, "You touch me when you do that." I would touch her leg before I would approach her and tape the ankle. And I said, "No, I don't." And she said, "Yes, you do." So I became consciously aware of it the next time I came up to the table, went to and realized, oh, well, yeah, I guess I do touch you before I actually start to tape your ankle. And so it's not about me and my willingness or wanting to be touchy and I touch people. It's not about me. But this particular athlete was uncomfortable with the additional touching that was taking place. So touching is real important for us to have an understanding. If you have to touch someone, how you touch them, there's cultural meaning and significance with regard to touching. And we really need to think about that. Asking permission to touch, as the young people say, back in the day when I was first starting in athletic training, we didn't ask people could we touch them. We just went ahead and touched them, did what we need to do, and went on about our business and didn't think twice about it. I had a young athlete in with me working a basketball tournament. The young man happened to pull his groin. He was about 8 years old, maybe. His mother came in with him. In the past, I would have evaluated that injury, touched him where I needed to touch him, and not thought about it. But I actually asked that young man, told him what I needed to do. This is what I need to do. This is where I need to touch you. Is it okay with you? He said yes. Turned to the mother. This is what I want to do. This is what I need to do. Is that okay with you? Person said yes. I kind of ran my fingers up the inside of that young man's leg, found and touched what I needed to, ran my fingers up the other leg, found what I needed it to do, and did and I was done. Didn't go back there again. Like I said, back in the day, wouldn't have thought twice about it. If my hand lingered, it lingered. If it didn't, it didn't. No one thought about it. Today, you have to think about it with regard to that. Religious considerations with regard to touch. If someone is fully covered and you are a male and this person is a female, they may not allow you to see them at all. We may need to have a same-sex person do the evaluation. That person's husband, father figure, male figure may be present during that evaluation. So you might need to take that into consideration as you are evaluating someone. Do you need to see it? What do you need to see? Who needs to be present while the touching is taking place? Gender considerations, again, male on male, female on female, male versus female. What are the issues that you may need to deal with? And as we think about genders and those individuals who may have multiple genders or who are consider themselves to be male, though they were born female. They consider themselves to be female, though they were born male. Some individuals who may choose to change their biological sex but haven't gone through the process. Those are issues that you may need to take into consideration as well when you touch and when you talk to individuals about what it is you're going to do and how it is that you are going to do it. Space, close personal space and contact. Again, how close, when we are working with our patients, how close do you need to be? When you're gathering the history, and that person may be sitting on the table or sitting on a chair, you may be sitting on a chair. How close are you standing to them? If you're leaning into the patient and the patient is busy leaning away from you, maybe they don't want to be that close, and maybe you should think about trying not to lean into them. If they keep leaning in, and they feel a need to be a little bit closer, resist the urge to lean out from that individual, because they may have the need to be a little bit more close. Again, it's not about us, but it's about the patient. What is it that helps them to be comfortable? And lastly, with regard to our palpating, expressions of pain. One of the things that we're doing is potentially eliciting pain when we do the palpation. So is the person stoic? Do they believe that to emote their pain is a sign of weakness, and they don't want to show that they're weak? So that person, you could push on them, and if you ask them on a scale of 10, 1 to 10, it would be a 10, but you would never know it when you actually touch the body part. On the other hand, someone who feels that emotive they need to share the pain with those around them. You could push on that individual and it's a 2, but you think that it's a 10 because of the way that they emote. So finding out and understanding how people express pain can go a long way in helping you with your palpation skills. Other cultural considerations not addressed as a part of taking the history or doing the inspection and observing or doing the palpating include time orientation and taboo times, future orientation versus present orientation. Future oriented individuals value clocks, they value being on time. In fact, they may be early to what it is that is going on, and they're looking into the future. They have calendars. Present oriented individuals are people who are dealing with the here and the now. They cannot even fathom what's going to take place in 10 minutes, let alone what's going to take place in an hour, what's going to take place 3 years from now. They're dealing with the present time, the here and now. Where we run into problems is where future time meets present time. Typically in the medical profession and athletic training, we want people on time. When we open up, when we close, when we do the evaluation, we want them on time. Well, if you're dealing with a present-oriented individual, they may be 10 minutes late, 15 minutes late, 20 minutes late, and don't think anything of it. They're not trying to be lazy. They're not trying to be disrespectful. They just don't have the same value of the timepiece as others may have, people in future time orientation. One of the things you may be able to do to deal with a present-oriented individual is tell them that their appointment is at noon, and in fact, the appointment is at 12:15. They arrive at 12:15. You know they're going to be there at 12:15. Everybody is happy. Now, if there's certain things where time is really critical, such as taking medications on a time schedule, then you need to emphasize that particular piece. But where possible, work with individuals with regard to their future and present orientedness. And then lastly, taboo times, ethnic and religious holidays. If they're individuals who pray during certain parts of the day, certainly being considerate of that time frame and allowing that to take place, maybe having a place if necessary, or rearranging the schedule to not conflict with those times and those holidays that may be problematic with regard to the athletic training schedule, finding ways to work through those times. In conclusion, I've talked a little bit about taking a history, taking and going through your inspection, your observation and palpation, and thinking about cultural related issues. Remember that all patients should have a culturally based physical assessment, not just those who, quote, look like they need a cultural assessment. Then you're trying to make determinations. Well, this one needs the cultural assessment. Maybe this one does, and no, that one not over there. Everyone, again, as I mentioned, culture is happening, whether in between or across, and whether we're on the same cultural book or not, or whether or not indeed there's cultural congruency or incongruency. So everyone needs to have a cultural assessment. And then lastly, I'd like to end with a quote from Shem that I like that says, "Knowledge about variations between groups does not allow one to assume that everyone in the group shares common beliefs, values, and practices. However, knowledge about variation does enhance the ability to ask better questions and to focus on assessing more effectively." Thank you.